next week we're not meeting. What I've done and what I will be doing is I uploaded endocrine for you guys. Okay, so we have endocrine online. It's my anatomy and physiology lecture because a lot of it is kind of repetitious in pathophysiology anyway. In addition to that, I also videotaped a small segment on diabetes because I wanted to go a little bit more in depth about diabetes. So you indeed will be tested on that, even though it's an A&P lecture. Okay, that is basically your endocrine lecture. Okay, you with me? So you have a quiz on it and it will be on your final. Now, I'm also going to upload my anatomy and physiology cardiovascular lectures. Now, I'll probably give you a quiz on that, but that won't be on the final because we will go into cardiovascular in pathophysiology. Are you with me? Okay, so endocrine for sure. You know, the heart one won't be on the final, but I may give you a little quiz just to get you reviewing that. Because when we get into cardiac, that's going to be one of the most important ones for you to review and go over because the structure of the heart is so complex. I want you to have a good working knowledge of the heart before we talk about it. Okay, so that'll be for next week. We're not meeting. Watch cardiovascular. Okay, watch endocrine online, and I will post quizzes for those probably next week at some point. Okay, I have the first quiz for central nervous system up. I'll open it tonight. The second quiz should be up by tonight or tomorrow night for the second half of central nervous system. Okay, any questions on any of that? No? Good. Okay, so there's that. Now, unfortunately, the cadaver trip is not going to happen. It turns out that they're starting to charge kind of a large amount to go there, which is understandable. And I can't really do financing. Hello. Hello. Come on in. I started a little bit early. Sorry. It's just so nice out. I wouldn't mind, you know. Okay. So it's pretty pricey. So unfortunately, we won't be able to. Now, if you're really, really interested, I probably will be going next spring. So if you are interested, you know, email me and say, took you, you know, your class with pathophysiology, you know, could I come with you to the cadavers? And then you could just come with us then. Okay. So unfortunately that fell through. Okay. So no trip. We talked about the endocrine lecture, the cardiovascular. The week after next week, we only have 3 more weeks after today, which is crazy. Next week, we're not meeting. The week after that, we're going to do pathophysiology of arterial disease, which is, I believe, chapter 9. If you want to read ahead. So we're going to move on. I think it's chapter 9. Arterial disease. 1, 2, 3. Okay, chapter 9, arterial disease. And then the next chapter is cardiac, I believe. Okay. Somebody have their book right there? I already have mine packed away. That's okay. Okay, so we'll move on to chapters 9 and 10 in 2 weeks. And then the final week we'll be doing respiratory. This is all we're going to be able to get through. But what I would like to do, if people are interested, if there's any other systems that you'd like me to upload my anatomy and physiology lectures for you to just watch on your own, I can do that for you. The 2 that I would like to post, and I may actually give you quizzes on, are GI, gastrointestinal, and reproductive, and probably kidney, ureter, bladder. I would not put those on your final, though. Are you with me? Okay, I may just give you quizzes to try to get you to look at some of the clinical stuff with those applications. Okay, so I'll let you know as we go along. And maybe I'll post one of them next week as well, in addition to the ones you already have to watch. All right, but I'll give you quizzes on those, and I'll put, like, if you'll be tested on them to sort of keep things straight. Just feel like there's so much more I want to go over with you, but time is of the essence, isn't it? Okay, so any questions about any of that before we move on? No? Okay, let me check my emails really quick. And see if anybody... No, okay, good. Looking good. Okay. So let's go on to we should be here. Okay, we should be, oops, sorry, people at home. I'm actually going to bring you in close so you can see this here. We're talking about central nervous system, sort of lumped into that. I put some musculoskeletal things, okay? One of them, we looked at scoliosis, we looked at kyphosis, we looked at lordosis last week. We looked at the general structure of the lobes of the brain. I gave you that silly little video, which is actually pretty good, okay? We talked about gray matter, and gray matter has cell bodies and some dendrites. So gray matter in the brain in general will help us to facilitate functions or thought processes, okay? White matter is going to be mostly axons. And those axons are covered by a fatty sheath called myelin. And that'll be areas where we transmit information, okay? So in the cortex of my brain, that thin outer layer of the brain, which is gray matter, if I think, oh, I want to move my right arm, a signal will come from that area of that brain, travel down through the white matter, right, down through a nerve and down to move my arm. Okay, so gray matter processes information in the brain, white matter helps to transmit it. Okay, you with me? So we've got the cortex on the outside, we've got white matter on the inside, which transmit. And then deep in the brain, deep in the brain, we actually have another grouping of gray matter. And that gray matter is going to help with more automatic functions. Breathing, relay of signals, heartbeat, regulation of hormones. Okay, so the outer cortex helps with more sensation and movement, and that deep collection of gray matter is going to help with more autonomic functions. Okay, just to give you a brief review of all those different structures. So now what we're looking at here is a herniated disc, and I think we're pretty familiar with this, but let's go into a little bit more specifics. When you're talking about the discs of the spine between the vertebra, the discs are structured like a jelly donut. Okay, if you can imagine a jelly donut and make it like 10 times harder than it is, and close off the hole, okay? That is sort of what the discs of the spine are structured like. I think sometimes we think that they're really just hard, almost calcified structures. They're not. They're cartilaginous. So if you were to imagine me holding on to that jelly donut, okay, remember it's much stronger, right? And I start to pinch it, what's going to happen to the jelly donut? The edges will start to bulge, right? If they bulge out and they start to break through that outer layer, okay, but they've completely broken through, that is called a bulging disc. People can have bulging discs that cause them problems and pain in their back and can pinch nerves, okay? And you can imagine that that bulge has kind of come out and pushed out onto a structure. Now, if I keep squeezing the jelly donut, squeeze, eventually what's going to happen? The jelly's going to pop out. Okay, that jelly is called the nucleus pulposus. It's right in the notes there somewhere. Okay, the nucleus pulposus. That's the jelly center of a disc. The annulus fibrosus is alternating layers of collagen. And those layers of collagen help to reinforce the disc and make it stronger. Are you with me? Okay. So if I squeeze that jelly donut, you know, I squeeze that disc, eventually that nucleus pulposus can come out. Okay. And if you look at the picture, you can see a picture on the left of a normal disc, okay? It's been cut, obviously, okay? So you can see the inside. And then on the right side, we have a herniated disc, and that's the jelly that's popped out. Now, unfortunately, what it likes to do is to push back onto the nerves that come out of the spine, okay? And you can see there, the spinal cord, just take a second and look at the spinal cord, and coming out of either side of the spinal cord is a nerve. Biomechanically, and if you really want to know why, come see me. It's a kind of long explanation. Biomechanically, what happens is discs like to move back, and that's where the spinal cord and the nerves are. And this is why when people blow a disc, they get what? Arm pain, leg pain, motor loss, sensory, paresthesias, okay? Because that's the way it likes to go. Can that bulge towards the front? Sure can, but that's going to be more of like an unusual injury, like a severe whiplash where they didn't have a headrest or, something like that. The most common areas that they will herniate or bulge will be back right next to those nerves, okay? Now, the other thing with the nucleus pulposus is the nucleus pulposus is totally encased by the time our immune system starts to develop. Okay, when our immune system develops, we send out like those T cells and those B cells, and they kind of roam around the body, and they sort of feel the body out. Like, oh, this is my liver, this is my kidney, this is my heart, this is all my tissue. They get used to the tissues of the body. What happens with the nucleus pulposus is it is encased before we get that immune surveillance going through our body. So what happens is the nucleus pulposus opens up, it pushes back, it's exposed, and what does our body think? Oh, we have foreign material, right? We have foreign material in our body, and it sends a ton of inflammation to that area. And that's why when people, oh, I heard the pop and now I can't move. Well, the pop was the herniation, and the can't move is that high level of inflammation that happens in that area, okay? And also compression of the nerve root as well. So herniated is different from bulging. I want you to know that difference. I mean, if you talk to an orthopedist and you don't know that difference, they'll be like, Bulging is that the nucleus has not come out yet. Herniated is when it has come out, okay? Okay, so where are we? What are we looking at here? Very good. We're looking at a vertebra, okay? And should the vertebra, I mean, obviously, if you have a really good radiologist, they'll put arrows on things for you, but for the most part, they're not gonna, right? If we didn't have the arrows there, that should still be an obvious deformity in that vertebra. The vertebra should be squarish. They're not gonna be perfect. Nothing in the body is a perfect symmetrical structure, okay? We've got that dark indentation there. So now going over what we just talked about, what do you think is happening here? What do you think might be happening? So we're at the vertebra. Between the vertebra, we've got the what? Oh, that's a problem. Okay, so let me explain to you what we're looking at here, because I could tell people are hesitating. We've got the vertebra here. We've got the nice bony vertebra. Okay, should be a square, not square, right? We see that dark indentation where the arrows are. Then we see that area of darkness underneath it, and then right underneath that we have another vertebra. Okay, so on the screen we have part of a vertebra at the bottom and then a full vertebra above that. The disc is in between, and because the disc is made up of cartilage, we can't see it. Okay, the denser a structure is on an x-ray, the whiter it will appear. Okay, and once again, if you want to know why for that, come see me at the break. I'm not going to get into it now. I mean, unless you really want, okay? So what's happened is one of those discs has herniated, but guess where it's herniated? Up into the vertebra. It's called a Schmorl's node, okay? Up into the vertebra. Does that ring a bell?
Well, I had an x-ray done and it said it on there, and I didn't know what it meant.
Yep.
I thought it meant I had some cancerous node in my vertebra or something, so I looked it up.
Oh my goodness. No, this is exactly what it is. You get a little herniation of it. Yes. My guess is that yours was probably not as extensive as this. Usually, this is pretty extensive. This is probably either somebody who has cancer that's spread to the spine, I'm guessing, is very osteoporotic, right? It would be my second guess. Usually with a Schmorl's node, it'll be just a small little wave. This is pretty extensive, but of course they're going to show the most extensive, in case studies. So, okay. So moving on, dural bleeding. Let me see what we have next. Okay, well, I'm going to keep people at home close here for now. Okay, so dural bleeding. So these will be different bleeds that'll happen in different areas around those meninges. Okay. Extradural bleed or epidural hematoma, okay, to be clinically correct, will be on top of the dura mater. Okay, now think in your brain again for just a second about those three layers of meninges. We've got the outermost layer is the dura mater. We've got that spider-like layer, which is in the middle, called arachnoid mater. And that arachnoid mater is very wispy thin, okay, very wispy thin. Backing up, the dura mater is like the consistency of a Glad bag, those dark bags that you put like your, garbage, your kitchen bags in, okay? And then on the brain itself is that pia mater, And the pia mater is right on the brain itself. You would actually have to take a scalpel and scrape it off, and you would scrape the cells off, okay? So the 3 layers. And those meninges help to provide an area of protection. But the other thing is that there's a different amount of blood vessels in different areas, okay? There are larger arteries on top of the dura, okay? There are larger arteries on top of the dura. Are you with me? Okay. There are also a fair amount of arteries between the arachnoid and the pia, okay? So this is why, guys, an epidural bleed and a subarachnoid bleed is more dangerous, okay? Because of the arterial supply being damaged in those areas more prevalently, but also what fluid do we see in the subarachnoid space? CSF, we see cerebral spinal fluid. So if we get a bleed that opens up into that subarachnoid space where CSF is, we're going to have more of a chance of infection, right? We're going to have more of a chance of infection. And there tends to be a little bit more, I think, a quicker bleeding with subarachnoid, okay? So extradural epidural is dangerous because you can get an arterial bleed, which will have high pressure. Are you with me? And if you have a high pressure, you're going to push a lot of blood into that area. And then what does that blood do? Is there anywhere to go? Do you remember that picture? Let's back up here. Here it is. Okay. So we have scalp, then we have bone, then we have dura, arachnoid, and pia. Is there a lot of space between those layers? No, there's like no space, right? And even where the cerebral spinal fluid is in that subarachnoid space, it's a thin, like filmy membrane. I think we think of cerebral spinal fluid as, I always used to think of it, before I, got into this material, that it was juicy. There was a fair amount there. There's not, okay? It's almost like a film. Okay, so there's not a lot of room. So bam, I get hit on the head. I get an epidural hematoma. I start to bleed with an artery being disrupted. There's a high amount of pressure. What is going to happen in the brain? You're going to increase intracranial pressure. Okay, so that is one of the dangers of that. Okay, same thing could happen with the other bleeds. If you get enough blood in there, you can increase intracranial pressure as well. Okay, so subarachnoid is going to be a little bit more predominant with arteries, okay? So a higher chance of an artery being damaged, higher pressure of blood flowing into that subarachnoid space, and also you're bleeding blood into that CSF, which is not good, okay? Breaking that blood-brain barrier. Subdural can be a little bit less intense. I think that more prevalently it's venous happening there, but we also don't have the cerebral spinal fluid in that area. But it could be dangerous as well, right? Because once again, we can increase pressure. Brain does not like pressure. Our brain does not do well with pressure on it. Nerves will stop functioning. And the other thing that I think is important, I'm going to move on to the next screen, and the other important thing I'll explain to you after we look at this. What's happening here? First of all, what are we looking at? Yeah, CAT scan of the head, right? The brain. Is that a hat on the right side? What?
I said it looks like there's a midline shift.
Absolutely, there's a midline shift. So the longitudinal fissure is shifted to the side because of the hematoma. Okay, there's a very predominant hematoma there. Now, the reason I wanted to move on to this before I talk about the next important thing is the increase of intracranial pressure. The brain does not have a lot of room to move. Okay? So if we increase pressure onto the brain, one of the things that can happen is it can start to push the brain down. If you push the brain down, what's the major opening that the spinal cord passes through? Foramen magnum. Foramen magnum. Okay, big hole is what it translates into. So the spinal cord will come through that foramen magnum. Okay, so if we start to push the brain down, we're going to compress the structures around that foramen magnum, aren't we? We could push the cerebellum down. It starts to pinch off the midbrain. If you start to pinch the midbrain, what starts to happen? You can have respiratory changes, you can have cardiovascular changes, okay, lots of autonomic functionings can start to change. You can also block off the exiting of cerebral spinal fluid. And if we block off that exiting of cerebral spinal fluid, what happens? Cerebral spinal fluid starts to back up into the brain, and now you're going to have a buildup of cerebral spinal fluid and causing hydrocephalus. Bad things can happen, okay? Bad things can happen. Okay, subdural hematoma, just to give you a little visual, you could see the bleed underneath the dura, okay? And then subarachnoid, and you can see one of the arteries there. And there's an aneurysm. We'll talk about aneurysms in a little bit. Okay. Any questions about any of that? No? Good? Excellent. Okay. So I'll do this song on break. I thought it was kind of cool. So one of those weird things, but anyway, so metabolism. So let me bring you guys at home back up. Okay, so metabolism. I just spoke about this with the endocrine lecture that I uploaded this morning. Okay, so this is important, and probably you guys know this, but you know, as we move into these things, the brain can only use glucose for energy. Yes. Okay. The brain can only use glucose for energy. The rest of the body, if we lose glucose levels or glucose levels decrease, we could tap into what for energy? Lipids or fats. Very good. Okay, it's not quite as efficient, but it works. Okay, but it works. So the brain can only use glucose though. So we go through a process called glucose sparing. Oh, it's there. Okay, good. Glucose sparing, where we'll turn over to fats in the body and save glucose for the brain. Okay, we'll turn to fats for the rest of the body and use glucose for the brain because the brain is that greedy. Okay, really needs glucose to keep going. And it's very metabolic. That's why if you don't breathe for several minutes, you start to get brain death because the brain is so metabolic and it constantly needs glucose and oxygen to keep functioning, keep regulating, or neurons start to die. Okay, and it needs constant perfusion. Now, you know, keep in mind we have that blood-brain barrier, but we need to perfuse the vessels that go up and around the brain so we can get the right amount of cerebral spinal fluid out so we can feed and nourish the brain. Okay, and feed the nerves directly. So cerebral blood flow. Do we remember what main blood vessels feed the brain? Mm-hmm. Which carotids? Internal or external carotids? Internal carotids are going to be two of the main that feed the brain. Vertebral arteries also feed the brain. Okay, so internal carotids and vertebral arteries will feed the brain. Okay, we need to maintain and regulate a certain amount of pressure constantly going up to the brain. So do I have this here? I don't. I do. Okay. So right about here-ish in the neck, you can feel your pulse, can't you? Okay, so that's obviously going to be common carotid bifurcating into internal and external carotid, right? So right where, do you guys remember that? Right? Yes, no? Okay, internal carotid is going to go up and feed the brain. External carotid comes to the outside of the head and neck region. Okay, let me bring people at home in a little bit more. Okay, so internal carotid is going to go up to the brain. External carotid goes to the external head region. Okay. What happens at that bifurcation of the internal and the external carotid, there's something called a carotid baroreceptor. Okay. Has anybody ever heard of carotid massage? Yes. Okay. What does carotid massage do? Somebody is really, really, really what? Before my hands get up there. Really tachycardia, right? Very hypertensive. You can do carotid massage, and what will it do? Drops their heart rate, drops their blood pressure, okay? That's because right at that bifurcation or that split, we have little nerve receptors called the carotid baroreceptors, and they sense pressure. And what they do is they regulate that systemic blood flow up to the brain to make sure it doesn't go too high or too low. Keeps it at a nice even pace. Okay, so that helps systemically. But we also have a change in the diameter of blood vessels in the brain itself. You know, if blood pressure goes too high, the blood vessels in the brain itself will constrict, so not so much blood can get through. If blood pressure really drops, they'll open up. So we've got systemic as well as localized responses to maintain that proper pressure, because we've all seen it. Okay, you've got the patient who's lying down, they sit up, they stand up, they do what? They drop back down, right? They're undergoing what? Orthostatic hypotension. Okay, they're not able to regulate the blood going to their brain. That may be a disease process like hypovolemia, or they've been sick, you know, high temperature. But quite often we also see it in elderly. Okay, and it's because their nervous system's just getting old. You know, those receptors are just not as acute or astute as they used to be. Okay, so that regulation over time will still start to falter a little bit. Okay, so regulation of systemic and also within the blood vessels themselves. Okay, and orthostatic hypotension we went over too. Okay, so moving on to cerebral vasculature. Do you guys remember this from A&P? No? Yes? No? All right, let me give you the gist. Because once again, you know, we're getting down to the wire, but I also want you guys to sort of get some take-home concepts from this stuff. You can see, okay, they have the, oh, my people at home, I'm sorry, let me bring you in on this. Okay, so you could see the internal carotid sort of, okay, let's start with this. You could see right around the center, it looks like a circle, yes? Okay, if you remember this, this is halfway home. It's called the Circle of Willis. It's called the Circle of Willis. What this Circle of Willis does is there are 4 arteries that feed it, the right and left internal carotids, the right and left vertebrals, okay? And then it flows in a circle. Well, isn't that brilliant? Because what happens? If one gets blocked, we have an anastomosis per se, okay? That would be a true anastomosis, but it's the concept of one. It can flow in from a different area, okay? Then we've got anterior cerebral, middle, and posterior cerebrals. And if you can remember that, you're 75% of the way home. Anterior is going to go to the front, middle is going to go to the side, posterior is going to go to the back. And then if you really want to get into neurology, if you have a general working knowledge of the areas that these vessels feed, you could sort of figure out what has happened in a stroke, right? Okay. If the right middle cerebral is dysfunctional, they could have some sort of auditory disturbances. You know, left cerebral could be some sort of speech disturbances. We're not going to get that far into it, okay? But just to give you an idea, okay? So Circle of Willis, please understand that the 2 vertebral arteries and the 2 internal carotid arteries are what feed this, okay? And it creates a bit of an anastomosis, albeit not perfect, okay? Now, looking at this, can you guys see that, my people in person? I put this up here because if we have an arterial supply, we've also got to have a venous drainage. Otherwise, you would have a buildup of all of the toxins in that area, okay? So the Circle of Willis is going to be the arterial blood supply. The venous drainage moves into what are called sinuses, okay? The sinuses will collect all of the blood, and the wastes from the cerebral spinal fluid, okay? There's superior sagittal, there's a straight sinus, there's sagittal, it is superior sagittal, superior sagittal, inferior sagittal, straight sinus, okay? And they all come together at this confluence of sinuses at the back of the head. Now, where that drains to is really what I want you to think of. I want you to think of these sinuses and where they drain to. They drain into what vein? What vein would drain the inner head region? What runs right next to the carotid? Jugular. Okay, so these will drain into the internal jugular. I think that's important to know. Okay, so all these dural sinuses, because they're actually made by little invaginations of the dura. All these dural sinuses will drain into the internal jugular. Are you with me? Okay. Okay. Now, blood-brain barrier. What I have here, I'm going to keep my people at home close in again. Okay, so I want you to just pause from taking notes for a second and try to envision this with me. I send arteries. I send the internal carotids and the vertebrals up to the brain to that circle of Willis, right? Now, are you going to transmit substances across those arteries? No, you've got to make the vessels smaller until they're what? Until they're one cell thick or capillaries, okay? It's the capillaries that will either feed the nerves or create cerebral spinal fluid in the brain area, okay? And what we're looking at here is a capillary that will be found in what are called the choroid plexus of the brain, okay? The choroid plexus is just a fancy word for the capillaries that are located inside the ventricles of the brain. Are you with me? Okay, so if I were to open up the ventricles and look inside, we would see a bunch of capillaries. And those capillaries will create cerebral spinal fluid that'll feed and nourish the brain. Are you with me? Okay, so this is one section of this capillary. It's going to be different from the capillaries in the rest of the body because between these cells we have tight junctions. And if we have tight junctions, it's going to form a much stronger barrier, isn't it? If we form a much stronger barrier, we're less likely to get, viruses and bacteria crossing across that membrane. Are you with me? In addition to having those tight junctions between those cells, see that little guy that looks almost like a, 20-footed octopus, kind of? That's called an astrocyte. Now, what an astrocyte does is it has these little foot processes that wrap around those capillaries, and guess what it does? It helps provide another barrier against substances that should not be entering the brain, or the cerebral spinal fluid, I should say. Okay. Are you with me with that? Okay. Okay. Yes? Okay. Once again, my people at home, if you have any questions about this, because this is, it's all tough stuff, but just shoot them to me. I'll check them on break. Okay. So this barrier is very important to prevent infections. Okay. We can get infections in though, can't we? And one of the theories I think that I've heard is that severe inflammation can cause a break in this barrier between these capillaries, or we could get infections that come up through the nasal cavity. Because if you think about it, how much do we prevent from getting into the body through our nasal cavity and the hairs of our nasal cavity? A lot, but some of it gets through. Your nasal nerves or the olfactory nerves are right in the roof of your nasal cavity. So one of the theories with meningitis is that it comes up, it gets on those olfactory nerves, and it goes up to the brain. Okay. So blood-brain barrier, very important, very good thing to have. Okay. Typical neuron, this should be familiar, right? The sensory information comes in through the dendrites. It's processed in the cell body, which has the nucleus. Then it goes out by the axon. You with me? Okay. And then the axon has these little pockets of what's called myelin. I want you to make a mental note of that. Okay, myelin. So that myelin forms these little nodes. Okay. And what that myelin does is it helps to facilitate the signals moving from that cell body to the next cell. Okay, so myelin facilitates or makes it quicker. There are nerves that don't have myelin on their axons. So would they be faster or slower? Slower. Okay. The myelin makes it much faster. We're talking like 2 meters per second to 200 for a fully myelinated versus non-myelinated axon. Okay. It's a big difference. So dendrites, cell body, axon, and the axon has the myelin around it. Now I want to talk for a minute about oligodendrocytes versus Schwann cells. Here we go with the big words. Okay. Let's group them together though. Both of them create myelin. Okay. Both of them create myelin. So both of them are going to make the myelin that go around axons. But there's one major difference. Oligodendrocytes are in the central nervous system. Schwann cells are in the peripheral nervous system. And there's one other major difference. So there's two major differences that I want you to know about them. Okay. So oligodendrocytes are in the central nervous system. Schwann cells are in the peripheral nervous system. Okay. The other big difference is if we damage axons in the central nervous system, Oligodendrocytes will not help to repair. That's why if you get damage in the central nervous system, it's permanent. Schwann cells create myelin in the peripheral nervous system. Am I going too fast? No, okay. Schwann cells create myelin in the peripheral nervous system that go around the axons of those peripheral nerves, but guess what Schwann cells do? If you bring the ends of that nerve together, the Schwann cells help it to repair. That's why let me just finish this thought. If you cut a nerve in the peripheral nervous system, they approximate it and sew it together, it can repair because those Schwann cells will help it to repair.
Aren't they trying to,
I know exactly what you're thinking. Yeah.
About Schwann cells being brought into the central
Yes,
nervous
they are.
system?
They are doing research of bringing the question was, are they using Schwann cells to help repair the central nervous system? Yes. They're bringing Schwann cells in to help. It's not working 100% of the time. There's some success to help facilitate the repair of the axons in the central nervous system. Good question. Okay. Good on that? Okay, good. So synaptic cleft. Oh, sweet Jesus. Okay. Did you guys remember this? Okay. All right. So hi people at home. We're back. We're still here. Okay. We're going to talk about the synaptic cleft. I think maybe it'll help if I draw it. So let's get the whole picture, first of all. Okay, let's get the whole picture. So we've got a nerve. Okay, that nerve is sending a signal down it. So my brain is going to tell my right fingers to wiggle. Let's use that as an example. Okay, so there's a series of nerves, but let's just say one nerve. Okay, so we send the signal from the cell body, says, okay, fingers wiggle, sends the signal down the axon. Okay, and at the end of the axon is where we're talking about now. Are you with me? Where the end of the axon goes against the muscles that innervate my nerves is where we are now. Okay, that is called the synaptic cleft. The end of an axon where it talks to the receptor, in this case it's going to be the muscles of my forearm, is the synaptic cleft. Okay? So, I always draw it this way. So this will be an axon. This will be the receptor. Now, why do I say receptor? Because it can be anything. It could be my muscles, it could be sphincters, it could be the GI tract. Okay, I use skeletal muscle because it's the most studied and it's the easiest to conceptualize. Okay, so fingers are moving. Send the signal down the axon, gets to the end of the axon. Okay, at the end of the axon, we actually have, and I'm not going to get a ton into this, little synaptic vesicles. Okay, and those synaptic vesicles contain neurotransmitters. And neurotransmitters are going to be little chemical signals that'll go from the axon to the receptor. In this case, in skeletal muscle, it's going to be acetylcholine. If you ever have to guess at a neurotransmitter in the peripheral nervous system, guess acetylcholine, okay, because it does a lot, okay? So acetylcholine. Okay, so that acetylcholine is in these little synaptic vesicles. We get a signal down that axon that tells those synaptic vesicles to open. We put neurotransmitter into this little synaptic cleft, and guess what it does? It attaches to the muscle and tells the muscle to function. Okay? So we have the signal down the nerve, but we also have that neurotransmitter, which is an important part of it as well. And that, guys, if you have that basic concept, there's all different types of neurotransmitters that you'll probably have to learn in pharmacology. Okay? Because it's whether you can inhibit it or accelerate it that medicines come into play, okay? But if you understand that synaptic cleft, you can understand some of those concepts, okay? You can understand some of those concepts, so synaptic cleft. So important to understand the receiving of messages that come from the central nervous system, yes? Any questions about that? Right, good. So moving on to support or glial cells. So there are different type of cells. We've already talked about the astrocytes. Those astrocytes are supporting cells that, I'm going to bring my people in home closer because we're going to look at some more pictures in just a second. Supporting cells or glial cells are found in the central nervous system. We have some in the peripheral as well, primarily those Schwann cells that help to support and nourish the nerves in the central nervous system. We've talked about two astrocytes, which are going to help form that blood-brain barrier, but those astrocytes also will bring nutrients, especially glucose and oxygen, from the bloodstream and give them to nerves. So astrocytes help to form that blood-brain barrier, but they also help to bring nutrients to nerve cells. Okay. Oligodendrocytes help to create myelin in the central nervous system. Oligodendrocytes help to create myelin in the central nervous system. Schwann cells are in the peripheral nervous system. Okay, you with me? Epididymal cells are simply a layer on those ventricles, a layer of like a cuboidal cell, I think it is, lining the ventricles of the brain. Now, what are the ventricles of the brain? What are the ventricles? We talked about them last week. They're areas that we create cerebral spinal fluid. They consist of three major groupings: the lateral ventricles, the third, and the fourth. Okay, that's right in the notes if you don't remember that. Okay, and they're all interconnected. Okay, they're all interconnected. So if I go down below the fourth ventricle and I pinch off that central canal that goes down to the spinal cord, we'll get backup of fluid back into the brain, yes? Okay, so did you?
Yeah.
How did it, what was the mechanism?
A vertebral dissection.
Ooh.
And she started becoming nauseous and like.
There you go.
Vomiting, and then
Stimulating the medulla.
they scanned her and she had a bleed that was blocking off the fourth ventricle.
Yeah, there you go. So one of the people in class said that a patient had a bleed that cut off the fourth ventricle, and then all that fluid will start to back up into the brain and put pressure on the brain. And I have a picture of that coming up in a little bit. Okay. So out of these cells, we can get one other concept I want to talk to you about. If you want to back up, I don't think you even really need this page or not. Don't forget with cancer. Okay, we just talked about cancer last week. Okay. Cancer is going to be prevalent in cells that replicate, right? Do nerves replicate? Oh, okay. Interesting, right? Well, guess where the cancer happens in the brain? It can't actually happen in the nerve cells. That's pretty rare. But it happens in those supporting cells. Okay, it happens in those supporting cells. They can be in specific areas, and I'll show you a picture of them in just a little bit. But to truly tell the difference, what would they have to do? Biopsy it and see which cell it was, okay, because they can present similarly. So epididymal cells, astrocytes and oligodendrocytes can all create cancer. Now, this is going to be an epidymoma, okay? Interestingly enough, epididymal cells line the ventricles. Now look at where this cancer is. It's in the ventricles, okay? So if you had to guess, and it's in the ventricle, I would maybe think of this potentially, okay? But once again, you would have to biopsy it to tell for sure. Astrocytoma is going to be, now this is more common. Well, there's also a ton of astrocytes, and those astrocytes are throughout the whole brain, okay? So it makes more sense that this is a little bit more common. Astrocytoma is going to come from those astrocytes, and you can see and this could go anywhere. It will enlarge the cells of that region, and once again, it'll start to push on the structures. You could see in the lower right-hand side of this picture the expansion of that lower quadrant of the brain. And it's also pushing up into the ventricles, isn't it? And misshaping those ventricles. Okay. Oligodendroloma. So these are going to be those oligodendrocytes. And you can see the CAT scan of this. Okay. Taking over a fair chunk of the brain there, unfortunately, hasn't it? This is going to be, I think, the least common. And some people call these in general gliomas. Okay, if they don't know specifically which one, you may hear the reference of gliomas. Okay, so structure and localized